Good afternoon, everyone. My name is Matt Seymour. As the president of the board of the Chicago Asthma Consortium, I'd like to welcome you all on behalf of my fellow board members to this afternoon's presentation on the latest asthma data. Regarding the schedule for this afternoon's forum, we'll have a series of prepared talks from the three presenters, and we'll save all questions until after the three presentations have been completed. A couple quick housekeeping items. First, to ensure that we can all see and hear the presenters, we ask that everyone just keep their audio muted and your video screen off. Though we're saving questions until the end, you can write questions in the chat at any time, and our moderator will make sure that they're directed to the appropriate person at the end. If you're having technical difficulties, you can please send a direct message to Asher in the chat, and they will assist you. After the presentation is ended, you'll also see a link in the chat for an evaluation. We'd appreciate it if you would complete the evaluation so that we can continue to offer the best, most relevant programming to all of us who are passionate about these issues and guidelines affecting people with asthma. A little bit about the CAC. We're an organization that seeks to improve the quality of life for people living with asthma in Chicago through advocacy, education, and collaboration among institutions working on asthma issues. CAC was formed 25 years ago. We're a completely volunteer membership organization, and our membership represents researchers, healthcare providers, activists, educators, as well as many Chicago residents who may not fall into any of these buckets, but who have asthma and are looking for ways to assist others with the same disease. If you're interested in helping us out, and if you're also passionate about issues affecting people with asthma, there are a couple ways you can help. The first one is to volunteer on one of our committees listed out here. These committees do extensive work to make a better environment for people with asthma. If I could ask everybody to put themselves on mute. Thank you. And whether it's standing up forums like this one through the Professional Development Committee, ensuring community representation in asthma research through the Community Advisory Board, directly presenting guidelines-based asthma education in community forums through the Community Engagement Committee, and much more. We always welcome new people to this effort. So that's one way you can be involved. The second one is to join our board of directors. That's the group of people that oversees the strategic direction of the Chicago Asthma Consortium and make sure that our collaborative work continues for the next 25 years. Finally, and importantly, you can become a member if you haven't already. Membership supports the efforts of the consortium, and you also get discounts on in-person forums, conferences, and more. Before we get started, I'd like to briefly acknowledge AstraZeneca. Their sponsorship is how we're able to keep a forum like this free of charge so that anyone interested in data presented here tonight can access it regardless of their ability to pay. So thank you to them.
It won't let me do.
And lastly, I'd like to introduce our moderator for tonight's forum, Dr. Anna Vollerman. Dr. Vollerman is an associate professor of medicine and pediatrics at the University of Chicago. She is a primary care physician for both children and adults and a health services researcher focused on improving systems and reducing inequalities in asthma. She's committed to reducing longstanding systemic and structural factors that impact inequalities through innovative approaches in clinical and community settings with the goal of helping children thrive across the settings where they live, learn, and play. Dr. Vollerman serves with me on the executive committee of the board of the Chicago Asthma Consortium, and she also serves as the co-chair of the data sharing committee of the Illinois Asthma Partnership. So thank you for leading us here tonight, Dr. Vollerman. And with that, I'll turn it over to you so that we can get the presentation started.
Great. Thank you so much, Matt. Welcome to everyone, and thank you for being here. I am truly excited about the information that will be shared over the hour and the rich discussion that will follow. We have three incredible leaders with us here around our state who have been dedicated to improving asthma care and asthma disparities for decades. We are hoping to use this time to share updates about what's been happening with asthma at the state, city, and county levels. In terms of logistics, each of our speakers will present for about 20 minutes. Please add comments, questions in the chat. And at the end, we will have a chance for a discussion about the findings and questions that emerge. To get us started, our first speaker will be Nancy Emerson. Nancy Emerson currently serves as the chronic disease epidemiologist at the Illinois Department of Public Health. She has worked in the Illinois asthma program since 2010 as the asthma epidemiologist and in the evaluator role for a short period of time. She is responsible for asthma surveillance activities and in disseminating those findings to partners and to the public. Prior to this position, Nancy served as the Public Health Prevention Service Fellow with the CDC for a year in Atlanta and 2 years in the Indian Health Service in Albuquerque, New Mexico, where she focused on chronic disease quality indicators and evaluation of the Improving Patient Care Program. Nancy earned her bachelor's degree from Millikan University and her MPH from the University of Illinois in Springfield. Nancy, I'm going to turn it over to you now.
Thank you, Anna. Okay, thank you. I am so excited to be here. Thank you for the invitation to share what's been going on with asthma surveillance in the state of Illinois over the past few years. Today, I will be showing you data that comes from our Illinois Department of Public Health hospital discharge data set, which includes our emergency department visits and our inpatient hospitalizations. We'll also look at asthma-related mortality, and I'll share some EMS data that looks at asthma-related ambulance visits to schools. All the data included in this presentation is through 2021. So I think first talk a little bit about asthma and COVID, as it's definitely affected the data we're going to be looking at. So that we all know that the relationship between asthma and COVID-19 continues to be very well researched and is evolving as the endemic continues. So we recently had a graduate student complete a literature review of asthma and COVID hospitalizations. It's available to you if you email me. My email address will be at the end. It's not on the website. And there's really varied findings when it comes to asthma and hospitalization with COVID. So we have one study showing that having asthma leads to worse COVID health outcomes, while one didn't find any differences and compared it to similar outcomes for when you have the flu and asthma. But what we do know is that respiratory illnesses are known to trigger the exacerbation of asthma. And again, in the data I'll show you today for Illinois, we see our asthma trends for ED visits, hospitalizations, and mortality very much affected by the COVID-19 pandemic in 2020 and 2021. In terms of who was sick with COVID, I think maybe everybody knows someone that's had COVID, but early in 2020, if you remember that far back, we saw our highest mortality among our older population, and that stayed true through 2021. In 2020, though, we saw the first sort of disparities, highest case rates among non-Hispanic Blacks and Hispanics, with some waves of very high rates among non-Hispanic whites. So it really kind of varied through the endemic. And we also have to consider what happened in 2020 with the stay-at-home mandate in place, as well as the closing of daycares and schools. And then in 2021, those opening up. And so we see how those may have, those trends and community measures have affected the data that we're going to look at today. So when it comes to our Illinois hospital discharge data set, we saw ED figures, ED, which is the figure on the left. We saw ED visits decline by 40%. In hospitalizations, that figure on the right, we saw it decline by almost 50% in 2020. And then though they bumped up a little bit in 2021, they haven't reached their sort of pre-COVID levels, which in 2016 through 2019 had been pretty level at that point. And this is the broad overview. Despite having sort of stable rates in the years before COVID, what we're not seeing here, but what we all know is that there's notable disparities by race, ethnicity, age groups, and gender. So here's a series of small multiple graphs of ED visits by age group, by different populations. I want to, before I dive in, I want to say that these are not all on the same scale. Most of them are on a scale of 140 per 10,000, except for the non-Hispanic Black, whose rates are so high that the scale is over twice as high as the other groups. But I didn't want to talk about exact numbers here, but rather to give a look at the trends by age group among those different populations. And so I think what you're first gravitating to is the yellow and the purple line, which is our 0 to 4 years in yellow and our 5 to 11-year-olds in purple. And these typically have the highest ED visit rate for all the different populations. These groups also had the most dramatic drop in 2020, and then also the greatest increase back up in 2021. We can also see in the 18 and 34-year-old group, which is the gray line, they had the highest rate in 2020 for overall, for non-Hispanic Black, non-Hispanic White, and for females. And I think these small multiples also display the ED disparities from a bird's eye view. Again, the non-Hispanic Black figure, which is the middle figure in the top row, each of the rates for those age-specific categories are 3 to 6 times higher than what we see in the Hispanic and the non-Hispanic White population. We also see males having a higher ED visit rate than females for the two youngest age groups, but females having higher rates than males for all the other age groups. For hospitalization, I think we're drawn again to this 0 to 4 year age group in yellow, having the greatest hospitalization rate for each figure displayed, and that the 5 to 11 year purple age group having the second highest for most of the figures except for Hispanic. We'll talk about that in a little bit. This remained true as the rates declined in 2020 and then ticked back up in 2021. And again, here, the non-Hispanic Black hospitalization rate scale is not the same as the other 5 figures because their rates are much higher than the other groups. When you do look at that Hispanic figure in the bottom, you can see that the oldest age group, the orange line, is the 65 plus years. They have the highest rate in 2019 and in 2020. And the female figure in the bottom right, we also see that they have the highest rate, inpatient hospitalization rate in females. So again, these small multiples display the inpatient hospitalization disparities from a very bird's eye view. The non-Hispanic Black figure has rates 5 times higher than Hispanic and non-Hispanic White for most age group comparisons for these inpatient hospitalizations. Males still have a higher hospitalization rate than females for those youngest age groups, while females have a higher rate than males for all the age groups for 18 years of age and older. Next, we'll look at asthma-related mortality trends. This is a screenshot from a death report. There are 2 parts for the cause of death where the coroner can fill in. So asthma-related deaths could be listed anywhere in part 1, the top part of this section, or in part 2 for significant conditions contributing to death. If asthma is the underlying cause of death, it would be listed in part 1 on the line that says C. So this is kind of a typical COVID-19 screenshot of a death record. So COVID-19 is the underlying cause of the death, but then you have these other conditions, including obesity and cardiovascular disease that are contributing to the death. Overall, the number of asthma-related deaths more than doubled in 2020 from an average of 370 a year to 773. Asthma as the underlying cause of death, which is the dark blue part of the bar, remained relatively stable in the 170s. However, as a percentage of all deaths, it dropped down from 47.2% in 2019 to 22.9%. So there was rather large increase in asthma as a contributing cause of mortality. This rise in asthma could be related obviously to COVID-19, where having asthma made people more susceptible to COVID-19 and contributed to the death. We do see the underlying cause of asthma drop in 2021 from 177 to 123. That could possibly be explained by maybe those with more severe asthma having passed away in 2020 from COVID. Asthma mortality rates, again, had been rather stable before COVID-19. We see that females have a higher mortality rate than males, and that they were sort of starting to converge closer to 2019, and now they're kind of widening again, where the female mortality rate is kind of getting away from the male mortality rate. Mortality rates are greater in the older population and really spiked with COVID-19 in the 65 and plus age group. Mortality in the less than 18-year-olds stayed pretty stable. That sort of medium blue line, the 35 to 64-year-olds, that's a 70% increase in 2020 compared to 2019. And then on the right, when we look at race ethnicity, the non-Hispanic Black disparity has the highest rate of mortality for asthma, and this disparity remained true through COVID years. We did see quite a jump, 6 times higher for Hispanics in 2020 compared to 2019, and 3 times higher for non-Hispanic other in 2020 compared to 2019. And lastly, I want to share some work a graduate student has done for us in our office looking at asthma-related ambulance visits to schools for children 5 to 18 years old. So asthma-related visits in our ambulance data was defined as having certain respiratory symptoms along with the administration of albuterol. And so this is actually a much larger project. We looked at a few different years. EMS changed versions in 2018. So we kind of have 2 separate data sets, a pre-2018 data set and then a 2019 onward data set. So this is just going to look at these last 3 years, 1 year, 2019, and then 2 years of COVID data. And we looked at county level rates for race and ethnicity. And we were able to look at some trends for some counties. Not every county had a stable rate because you must have a count of S20 for us to produce that. But this is what we found. The tables are sorted by the 2021 crude rate per 10,000 population for those aged 5 to 18 by county. I did include Cook County on the list. They're kind of grayed out because they weren't in the sort of like the top tier, but we know that they're our highest populated county, so we always want to take a look at them. So the table on the left shows the counties with the highest non-Hispanic Black EMS rates, and on the right we have the non-Hispanic White EMS rates. Rates in red are showing an increase in 2021 compared to 2019. Rates in green are showing a decrease between those years. There's this natural dip in 2020, which we know is most likely due from the fact that most public schools were closed for half of 2020. What we can see here is that what's really interesting is that the non-Hispanic rates increased from 2019 to 2021 for those kind of, for these top 9 counties, for most of them, whereas the non-Hispanic White, the difference in the 3 years are showing decreases. And then generally just the degree of the rate. So we've got triple digit rates here for non-Hispanic Black compared to rates in the 20s here for non-Hispanic Whites. So for example, in Cook County, the non-Hispanic Black rate of 39.4 is 11 times higher than the non-Hispanic White rate of 3.4. So this is definitely a data set that we want to look into more as we're doing our asthma surveillance. So in summary, we saw our ED visits and our inpatient hospitalizations decrease during 2020 and remain lower in 2021 than our pre-COVID data. Our mortality increased during 2020 and remains higher in 2021 compared to pre-COVID. And our asthma-related EMS visits have increased for the non-Hispanic Black populations in high-rate counties, but decreased for non-Hispanic White in high-rate counties. And so the disparity gap is really not closing in a lot of the asthma measures that we've looked at today. I would like to just close, say thank you, remind you that we are holding questions till the end. And so I will turn it over to, I think, Erica.
I'll go ahead and introduce Erica. Nancy, thank you very much for the insightful presentation.
Oh, no, I hand it over to you. Sorry, Anna.
You're totally good. Thank you very much. So next we will have Erica Seitlum. Erica is the Senior Director of Strategy, Programs, and Policy at the Respiratory Health Association. In this role, Erica oversees all of the association's mission-related work: tobacco, asthma, COPD, environmental health, and advocacy and policy development. Erica has worked closely with state, local, and community partners, which share RHA's commitment to the reduction of health disparities. Notably, Erica is a public health professional with over 30 years of experience, including 25 years at the Chicago Department of Public Health, where she most recently served as deputy commissioner. Much of her work there focused on collaborative planning and partnerships. She earned her master's of public health from the University of North Carolina in Chapel Hill. Erica, I'm going to turn it over to you to talk about asthma at the city level.
Thanks, Anna. Just a second. I'm sorry, I'm trying to share. Can you see my slides? Yeah. Okay. Yeah, I want to talk about racial disparities that are continuing in childhood asthma among Chicagoans. I'm going to share some of the recent data that we have on emergency department visits in Chicago, talk briefly about what's working, and by sharing a list of problems that we're still facing. Data is the same data sources that Nancy just presented on, and I want to acknowledge Nancy and her team for their support in analyzing and pulling these data for us. So I'm looking only at pediatric asthma-related emergency department visits. Pediatric data are age 0 to 19 by race and year from 2016 to 2021. And then briefly emergency medical services database from IDPH, which is just aggregated by race for the 6-year period. So during the past 6 years, there were just over 23,000 asthma-related emergency room visits among children 0 to 19. The vast majority of these visits, 70%, were among older children 5 to 19. The younger children made up about 30% of the visits, except in the year of COVID 2020, when just 23% of total visits were in this age group. By race, for 0 to 4-year-olds, you can see in the red bar here that Black children comprised 40% of the more than 7,000 visits. Over this 6-year period, Hispanics accounted for 27% and whites 23%. Looking at 5 to 19-year-olds, Black children then made up 53% of the majority of these visits to the hospital, and lower rates, again, Hispanic and white children, 23% and 16% respectively. So the rates are where the rubber meets the road with the asthma data, and these are rates per 10,000 population. Between 2016 and 2019, the year before the pandemic, the rate of ED visits among 0 to 4-year-olds in the dark bar increased by 3%. And then from 2019 on, it declined by 40%. 5 to 19-year-olds were actually already declining the rates of visits at, by 11% between 2016 and 19, and that decrease sped up to 44.5% during the pandemic. So for 0 to 4-year-olds, I'm looking at the Black-white disparities and seeing that there's no movement on the racial gap. So for 0 to 4-year-olds, Black children in 2016 and in 2021 were 2.5 times more likely to go to the emergency room than their white counterparts. And among 5 to 19-year-olds, things didn't even say stable, they got worse. So in 2021, Black child was 4.3 times more likely to have an asthma-related emergency department visit than white child. And this is actually a 9% increase from the 3.9% racial gap in 2016. So there are several things. I mean, the news of the growing disparities is really troubling to myself and a lot of colleagues, because there is so much that's working, and there's some of the things I'll touch on very briefly here. In 2018, many of us worked successfully on the passage of legislation that would allow but not require schools to maintain a stock of undesignated asthma rescue medication. So this could be administered by a trained nurse or any other trained staff when a student has an asthma emergency during the school day or on school property. In 2020, we developed guidance for schools in partnership with IDPH and the State Board of Education and many colleagues. In 2021, we were able to develop the training that is required by the legislation, again with IDPH and school board, the Illinois School Board of School Education Board. And then in 2022, we got some funding. The state increased its funding for asthma programs by $1 million. This was the first significant investment the state had made in direct asthma programming. Most of their funding comes from a CDC grant. So this was a big victory. We also have new data, as Nancy shared. She's been able to make available for everyone the emergency medical system service visits to schools, so we can better target where our efforts should go. But the bad news, of course, in Chicago is that 74% of the visits in the last 6 years were in response to emergencies from Black students, who really just comprise less than a third of school-age children in Chicago. We have also been able to do more collaborative work. This is an example of a recently state-funded project between Respiratory Health Association, University of Chicago Medicine, Mobile Care Chicago, and Sinai Urban Health Institute. In this model, we are all focused on the same students from the same schools, offering them a continuum of services. We've always wanted to collaborate, but it hasn't been possible without this state support. So here's where there's room for improvement, and there's lots of room for improvement and a lot of questions. I have a question about the role of schools in asthma emergencies. In 2018, the Sun-Times did an expose on dirty schools and how a contractor, Aramark, had been falsifying their records to make schools look cleaner than they are. And the schools system immediately terminated that contract and said they'd never hire them again. And then 2 years later, they hired them again. And now we're back where we started from, with complaints about dirty schools. Asthma ED visits went down a lot during the pandemic among children. And there are hypotheses about what role the kids not being in school might have played in that. Are some of them less exposed to triggers because they're not in their dirty schools? Now, to be fair, all emergency room visits went down during the pandemic for all causes. But there are numerous studies showing that the greatest reductions for ED visits were in asthma and other respiratory conditions. So this is a question I have. I think there are probably multiple causes for the decrease in ED visits, but I would guess that exposure to triggers in dirty schools is among that list. I also think that there is more research that is needed in this area, because on paper, we are doing everything right. We are targeting the schools with the highest asthma rates, or with the highest, in communities with the highest ED visits. We are providing evidence-based clinical care that seems to be helping. Yet, among younger children, it's not making a difference. And among older children, the gap is getting wider. So I think there needs to be a fair amount of research so that we can better understand these growing disparities and respond to them. This is a pie chart from the 2022 City of Chicago budget book, and this is the health department's budget by program area. The orange arrow leading to 0% represents chronic disease funding from the City of Chicago in their budget. Now, it's less than 1%, it's more than 0%. But most of that money is for tobacco. The city health department has never invested in asthma prevention programming or an asthma management programming, at least in the 25 years that I was there and in the 5 to 7 years since I left. And this is something we have been advocating for. Everyone there says it's important, but they don't have the grant funding. Which leads me to my last conundrum, which is, how can we achieve a balance between the focus on social determinants of health and racial equity and the need to continue the provision of basic public health services? As we move more towards a social determinants of health lens, we are looking to public health solutions such as housing and jobs, and family income. And these are all important, but I would argue that so is asthma programming, so is lung health programming and direct services. And from where I'm sitting, I am seeing, certainly with chronic disease, that a price is being paid with chronic disease programs with this increased focus. I completely support a focus on social determinants of health and racial equity, absolutely, but I think we need to achieve a better balance. And that is what I wanted to share with you today. This is my email if anyone has any questions, and I'm going to turn it back over to Anna.
Thank you, Erica, for another insightful presentation. I just want to remind folks, if you have questions, ideas, comments, feel free to send them in the chat. You can send them directly to me at Anna Vollerman, or you can share them with everyone based on your preference. Our last speaker for today will be Amy O'Rourke. Amy serves as the Director for Chronic Disease Prevention and Control at the Cook County Department of Public Health. In this role, she strategically leads the Chronic Disease Prevention and Control Unit to reduce the burden of chronic disease and promote healthy eating, active living, and tobacco-free communities in suburban Cook County through policy, systems, and environment approaches. Prior to joining CCDPH, Amy served as Director of Programs at Respiratory Health Association. In this role, she led their asthma and COPD programs team to reduce the burden of chronic lung disease through education, policy change, and research. She directed the implementation of evidence-based asthma self-management interventions for children living with asthma. She also supported statewide chronic disease policy efforts, including the successful passage of asthma emergency response protocols for schools and undesignated asthma rescue medication in schools. Amy previously served as a board member of the Chicago Asthma Consortium and received her bachelor's degree in molecular biology and her MPH from Benedictine University in Illinois. Amy, I'm going to turn it over to you now to talk about the Cook County level information.
Great, thank you so much, Anna, and thank you again for including Cook County Department of Public Health in this important discussion. Before we jump into suburban Cook County asthma data, and I know I'm working with Asher to pull up the slide deck, I wanted to provide just a brief overview of the Cook County Department of Public Health in our jurisdiction. At Cook County Department of Public Health, we are a state certified health department. And we serve more than 2.5 million people in 127 Chicago suburbs, excluding though Evanston, Oak Park, Skokie, and Stickney Township. Each of which of the 127 municipalities have their own elected officials. So we have a complex jurisdiction spanning 700 square miles. At the core of our health department's work, though, we focus on advancing health equity for all people, whether it's supporting policies like undesignated asthma medication in schools, investigating communicable disease, responding to the COVID-19 pandemic, case managing high-risk infants, or preventing tobacco use. Again, it's important to note suburban Cook County, our jurisdiction, is home to some of the most affluent communities and some of the most resource-strapped communities in the nation. And it has been growing more diverse over the years as well. Health inequities we recognize and we know exist by race in place, which will be highlighted throughout the presentation, and asthma specific data we'll go over shortly. We know that policies and practices that have systematically disadvantaged people of color and benefited white people, such as unfair housing practices and low minimum wage, have generated unfair and avoidable differences in life expectancy and health. We know that the pandemic, unfortunately, has also highlighted in bold relief the disparities that we're familiar with, and you are as well, especially in our south and west suburbs. COVID has, as we've heard, has worsened chronic conditions and pre-existing issues like unemployment, access to medical care, healthy foods, places to be active, and housing insecurity. So with all of that being said, again, I'm happy to be a part of this conversation today and highlighting some of the specific data for suburban Cook County. So with that, Asher, I'm ready to move on to the next slide. We're going to be taking a look in suburban Cook County at emergency department or hospital data for 2016 to 2020 and by vital statistics data from 2016 to 2020. So we'll look at asthma prevalence, which is some CDC leveraging census tract data and BRFSS data to highlight prevalence of asthma in adults. In suburban Cook County, we'll take a look at asthma-related emergency department visits among broken down by age, as well as then by race and ethnicity. And then we'll spend some time towards the tail end talking about the health department and our partners' response, how we're working with others to respond to the disparities that we know exist and have already been highlighted. Next slide. So as far as asthma in adults in suburban Cook County, again, what we're seeing as this map represents, the darker regions or the darker areas represent higher prevalence or most prevalence. We're seeing more prevalence. Asthma in adults is most prevalent in the west and south side of Chicago, and that mirrors in suburban Cook County. So again, our areas of concern are in the south suburbs and western suburban Cook County. And we'll see some maps that talk about specifically not prevalence, but ED visits and the burden of ED visits on communities and what communities experience higher ED visits. Next slide, please. We're going to look right now at emergency department visits by age in suburban Cook County between 2016 and 2020. I just wanted to point out the blue bars here in this graph show children and young adults, and the red bars highlight individuals that are 20 and over. Much like what we've already heard, ED visits for asthma are higher among children and young adults in comparison to adults. visits. Rates among each age group remained pretty consistent from 2016 to 2019 in our jurisdiction, as we've heard from the other presentations statewide and in Chicago as well. Rates in 2020, though, we did see a significant decline, as has already been pointed out. It's important for us to interpret this with caution due to the COVID-19 pandemic. We're still trying to understand why this is the case. Next slide, please. This map represents asthma-related ED visits and the higher rates, the rates of ED visits for ages 0 to 4 in Cook County. What we see here is the dark blue, or the darkest blue, represents the highest ED visit rates among children 0 to 4. Highest rates are observed in the South and West communities. One thing to note, you do see some communities in the North also indicated as the darkest blue, but just that's due to some partial populations overlapping with other counties, and it's biasing some of our data, the denominators, causing inflated rates. So you can disregard that. The focus should be on the West and South areas, because those are truly the areas that are experiencing the highest rates of ED, asthma-related ED visits. The next slide, we're going to highlight then 5 to 19-year-olds. Again, similar to the previous map, we're seeing clusters in the West and Southern region. You'll see more areas in the Southern region, darker blue, meaning higher rates of asthma-related ED visits. Rates are highest, it's also important to point out, rates are highest in both pediatric groups, 0 to 4 and 5 to 19, in specific communities we're experiencing in suburban Cook County, or noticing in observing in suburban Cook County: Broadview, Hillside, South Holland, Matson, and Calumet City. You can advance to the next slide. When looking at those slides or those maps of ED, asthma-related ED visits, it looks very similar to a map that we looked at throughout COVID to help tell suburban Cook County, or our department, our health department, Cook County Department of Public Health, how to direct COVID-19 specific resources to help address the communities that are most vulnerable and most impacted. So we use something within the health department called social vulnerability index scores. This is a score or index from the CDC that we leverage. And again, looking at the previous 2 slides maps, you'll see communities in the West and South region being communities on this map that represent the highest social vulnerability scores, meaning they're more vulnerable during any type of they may be more vulnerable, or likely to be more vulnerable during any type of major disaster, public health event like COVID. So again, we leverage this type of tool to help have a data-informed approach to responding to disasters or public health emergencies. But again, it's hard to not look at the previous slides or maps and not see the similarities with this map. So again, what we're seeing is our most vulnerable communities in suburban Cook County are experiencing the highest rates of asthma-related ED visits. You can advance to the next slide. Now we're going to take a closer look of asthma-related ED visits by race and ethnicity between 2016 and 2020. It's important to note that this slide represents all age groups, so both children and adults. And just to point out, the peach bar represents non-Hispanic Black, the dark blue is non-Hispanic White, red bar represents Hispanic, and teal represents non-Hispanic Asian. Again, asthma-related ED visits are consistently highest among non-Hispanic Black populations. And this is disproportionate to their share of the whole Cook County population. So again, this is alarming. Rates are additionally high among Hispanic populations, and as you can see through this bar graph, are lowest among non-Hispanic White and Asian populations. You can advance to the next slide. When we're taking a closer look then by age and race and ethnicity. So I'm just going to point out how you can orient yourself to this slide and this graph. So the dashed lines represent adults and solid lines represent youth. Dark red line represents non-Hispanic Black. Teal lines represent Hispanic populations, purple lines represent non-Hispanic white. And then I think it's the yellow line that's representing the non-Hispanic Asian. Unfortunately, similar trends are observed as in the previous slide, showing disparities between both non-Hispanic Black and Hispanic populations, and non-Hispanic white and non-Hispanic Asian populations are prevalent among both youth and adult groups. Rates appear similar among non-Hispanic Asian and non-Hispanic white groups, youth, and are lowest among non-Hispanic Asian and non-Hispanic white adults. Next slide, we're going to take in a zoomed in approach or look at youth. So we're looking by age and race and ethnicity, excuse me. So again, trends when looking within youth, age 19 and below, groups are consistent with the previous slides. We're seeing youngest age group 0 to 4 report more frequently to the emergency department. Rates are highest among non-Hispanic Black populations, which are represented by the red lines of both age groups examined, and more variation was observed in rates among non-Hispanic Black residents age 4 and below. You can advance to the next slide. So when we're talking about ways in which we can collectively, and from the health department's perspective, ways we can work with partners to address asthma disparities, I think it's important for us all to reflect on the questions that Erica raised at the tail end of her presentation, because I think those are real questions we need to all collectively ask. What can we collectively do? And what is this balance between programmatic work as well as these upstream approaches to addressing social determinants and health inequities? Because again, downstream, we're seeing worse health outcomes of people living with these conditions. So how can we balance that? So at the health department, that's something we're still looking to address and identify ways in which we can play a role with our partners to address these disparities. One of the ways that we're looking to support this is supporting implementation of the stock asthma rescue medication in schools across suburban Cook County schools. So again, it's working with suburban Cook County schools, working with the intermediate service centers, the regional offices of education that represent superintendents across our region, to increase awareness of this law and connect schools with tools and resources to support implementation, especially schools in the west and south sides of suburban Cook County. We are exploring currently CCDPH's role in issuing freestanding orders and prescriptions for schools to stock undesignated asthma rescue medication, similar to what we do with our school epinephrine program. So again, we know that not having a standing order or prescription from a healthcare provider may be a barrier for a school district in implementing and stocking this life-saving medication. So again, we're exploring ways that the health department can issue those standing orders and prescriptions, similar to other programs that we've already put into place. And we're actively participating in RHA's new implementation advisory committee to explore ways in which we can connect resources or drive resources, these needed resources, to schools, because we know that cost, training, et cetera, could be potential limitations to their participation. In addition to implementation of policies that are big P policies that are put into place, we're exploring ways that we can expand our existing programmatic and resources we're bringing to the community. So one way we're exploring is expanding our existing lead prevention program to incorporate not only in-home lead inspections, but to expand that to do an assessment of asthma triggers, and then not only to assess for those asthma triggers, connect to trigger remediation resources. So we're leveraging a number of new funding sources to expand our lead prevention programming so that we can do more within the homes of individuals, address the potential triggers within the homes, and connect them to resources to support with that remediation. As far as expanding care coordination, we are looking to support expansion, or we are actively expanding community-based community health programming with grant funding and technical assistance. We're looking to increase healthcare coordination and linkage to critical healthcare so that individuals living with asthma can better manage their asthma with the appropriate healthcare support and receive that critical information education around trigger avoidance, around proper medication usage, proper medication technique, and how to spot and respond to respiratory distress. So again, we see community health workers as key in that. So we're working with community-based organizations to either expand or begin new CHW programs across the region, leveraging some federal funding we've received recently. We continue to enforce the Cook County Clean Indoor Air Ordinance and working with partners to advance local tobacco-related policies, systems, and environmental change strategies to make the environments healthier and safer for everyone living with asthma, so that they can appropriately avoid tobacco smoke as one of their potential triggers. And then we're promoting asthma management education programs like Respiratory Health Association's programming for children and adult caregivers in suburban Cook County. So finding ways to connect schools to those existing resources so that they can be properly prepared to prevent and manage emergencies in schools. So with that, I think I'm going to pause and turn it back over to Anna so that we can go over the questions that are popping up in the chat.
Yeah, thank you very much, Amy. What a tremendous set of presentations from each of the speakers today. It's incredible just to appreciate how much information is available, but also taking nuanced perspectives on it, right? Digging into certain populations, digging into certain communities, and really, overlaying it with some of the other health issues and public health and societal factors. So, I'm going to start with some of the questions that we got, that we received from participants. There's been a healthy discussion in the chat about environmental factors and the role of pollution, the role of air quality, both outdoor and indoor air quality. But I will ask focus on one specific question related to indoor and outdoor air quality related to schools. So how are schools addressing outdoor air quality exposures such as bus and car exhausts? And how are they measuring and addressing indoor air quality, particularly as related to air conditioning systems?
Well, I mean, there is a law, at least in Chicago, right? School bus idling. To my knowledge, from what I experienced in, the 12, 14 years my kids were in school, that's not enforced. So I don't know beyond the fact that I think there's not enough enforcement being done, but there's attention for schools. Their priority is education, understandably, right? So to get them to focus on asthma is tough. It's really tough.
So a really fair point, Erica. There's many competing priorities they're focusing on, and important to think about, whose responsibility is it to focus on the bus idling and the air conditioning systems, right, and things like that, right? Who does that fall under the pretense of a principal, maintenance individual, security person, etc., right? And many of us would probably say it falls under everybody, but that actually dilutes the responsibility and takes it away, it can take away some of the enforcement. I want to follow up with a question, and there was quite a bit of focus, in addition to presenting specific numbers in various populations. It was clear that there's quite a bit of disparities that we see. what do you, envision as some of the main drivers of those disparities? And particularly, to Matt's question, and he brought up, particularly related to the EMS data, what could be driving the large gaps that we're seeing in terms of race and ethnicity?
I think the same issues with the schools, the EMS visits is what's driving the disparities with the hospital visits. I do think that a fair amount of this does have to do with social determinants of health, like Amy was mentioning, the jobs and the housing, and that is all important. And that's why I struggle with the issue, because if you only focus on that, then you're almost writing off a generation because you're not supporting them with what you need at the moment as a person living with asthma, right? So I do think the housing makes a difference, the quality of the local environment, the industrial businesses. They're, you saw with General Iron, the move from Lincoln Park to South Chicago. So we're moving from whites to Hispanics. There is, the development of these warehouses and these kind of last minute miles of, getting packaging off the train, and then these big diesel engine polluting trucks driving through neighborhoods to get to these warehouses. I think that makes a difference as well.
Thanks, Erica. Nancy, I wanted to give you a chance to comment also, because you shared some fairly striking data related to EMS and the use of EMS.
Yeah, sure. The disparities in general, I think Erica and Amy actually did a really good job talking about social determinants of health. I know from a statewide perspective, when you're charged with CDC funding on how you're going to focus and what you're going to look at, we're sticking to supporting our funded partners and unfunded partners and any sort of policy work that they're doing. We're focused on the CDC Exhale package, like a comprehensive approach. I think that's been lacking in the past as we focus in on one sort of project, but the social determinants of health in the communities, there's so much to navigate. Having that clinical community linkage part too, and being able to engage multiple partners from different sectors, I think is one way to start addressing social determinants of health, just regardless of asthma status. Specifically for the EMS visits, I don't know if I have a hypothesis on why it's so different. I think probably just institutionalized disparities are just really hard to overcome. And I hope that we can use EMS data and do more work. And I know that Erica and her partners, with some of the funding they're using from the state asthma funds, are going to use that data to help focus and target schools for the albuterol policy implementation. So just respond.
And Anna, this could also be another area of study. To what extent are lower income students able to bring an inhaler to school and bring it home? Not every family can afford 2 inhalers. So the question is, are there more low income children of color who don't have an inhaler at school?
Yeah, we're lacking a lot of data on asthma in schools, right? And that's partly because of the data collection that happens at the schools, how it's not online. If you really want to get into a school and find out, you're going to have to do chart audits of their health. It's just not like a comprehensive way to evaluate and assess that.
And even with chart audits, you're going to find incomplete charts,
Definitely.
right?
The only way to really find out is to show up to school on a random day and ask a child, can you show me your asthma inhaler? Right.
Right.
And see if they truly have it with them. Right. That's, I mean,
Yeah.
you know, is it with them, or is it in their backpack in their locker and things like that? Or is it even with them? I think the piece about inhalers and 2 inhalers specifically is an important consideration, because we have to acknowledge the cost of those inhalers, and also the insurance policies that, you know, often prevent more than one inhaler being dispensed at a time. My next question is related to, you know, it was interesting to see, right? So this is actually, Nancy, you shared some really interesting data about EMS visits, and this, I would say, is, you know, I've seen some very local data that RHA has shared, but it's great to see this focus on EMS. And looking at the data that you shared, Nancy, you know, it wasn't all in the same direction, if that makes sense, right? Like, we would expect everything would get worse if it was, you know, and so how do you account for those changes, right? That some are getting worse, but some are seemingly not getting worse, not appearing worse. What do you think that suggests about asthma care, about coordination, about the healthcare system?
I think when we're looking at 2020 and 2021 data, it's hard to figure out how COVID is affecting asthma in kids, especially in this, because that project was specifically for ambulance visits to schools, private schools versus public schools, who was making the kids mask longer or not mask longer. I think those all could all be factors. I was really surprised by the EMS findings, and I haven't had time to really delve in and think more about that. The University of Illinois Urbana-Champaign on our evaluation team are really interested in that too, so I know it's something we're going to look more closely at. I don't know, you know, and the population density of some of those counties with the highest non-Hispanic Black rates are kind of lower population counties in terms of non-white populations. So that's really interesting too. I think we need to look at it more.
It's interesting to consider, you know, is the use of EMS simply a measure of access to transportation or financial impacts that then, you know, affected the use of public transportation or other transportation means, or what does it, you know, suggest overall about asthma? So it's a consideration, you know, it's at different stages throughout the pandemic. Individuals had different comfort levels and have continued to have different comfort levels about accessing the healthcare system. And so I think that's, you know, another consideration. The next question, Nancy, is also directed to you. And I promise we will direct to others afterwards, but some of the early research suggested that individuals with asthma were not likely to have more severe asthma, yet there's that increase in asthma-related mortality. What might explain that?
The only thing I can think of is that perhaps when they were looking at asthma mortality, perhaps they were looking at asthma as the primary reason for the death versus a contributing factor, because it was interesting that asthma as the primary reason kind of remained constant in it is very similar in 2020, but those contributing asthma deaths really skyrocketed. And so I don't know if it has to do also with as they got further into 2020 and documenting deaths related to COVID, that they got better with their death certificate, you know, because that was sort of, you know, having COVID be, you know, the contributing cause of death and then finding all the other factors. That could be one hypothesis, is that it was a data collection issue, or it was a definition of mortality issue, because there's no way around it that, I mean, it more than doubled, and the asthma as a contributing cause to death just really skyrocketed. So it definitely has to do with COVID-19. But I don't know why the early reports, you know, said there wasn't as potentially a COVID asthma link. I'm not sure. Maybe another lit review is needed. See how it's changed.
Thanks, Nancy.
Mhm.
For our participants, there's been a robust discussion in the chat, but if you have additional questions you'd like me to raise with the group, please let me know. I want to transition to talking about the data, to talking about, you know, where do we go from here, right? What do we do? How can we change the direction so that when we're having a similar forum in 5 years, the story is different? And maybe I'll start with Amy. You know, what would you say are the, you know, the 1 or 2 places that where the focus should be?
Yeah, that's a great question. So I think, I mean, obviously, I think Erica pointed out, you know, the lack of resources being dedicated to addressing, you know, these issues. So while, you know, resources are going to, you know, the public health issue of the day, and, you know, emergency response, you know, COVID-19, that's been our attention as the health department's, you know, primary response role. You know, it's how do we still continue to offer, you know, resources, provide resources, invest people, time, funding to support, you know, people living with asthma. So I think resources are key. So how can we continuously drive resources towards, you know, people's care, accessing proper medication, and addressing the environment that they're within. So whether it's trigger remediation or addressing air pollution, you know, or, you know, other environmental pollutants in their community area, that all takes resources, time, and dedication. So that's, you know, one area that I think is so critical. And one area that I just want to highlight and shout out to RHA and other partners that were a part of securing funding in the state budget to support with accessing asthma emergency medication. You know, earmarking those dollars so that schools could access that medication. I think, you know, any way that we can collectively drive more resources towards these issues is really going to help move the needle, Anna, to your point. And then I think it's, you know, there's so much happening, as Erica pointed out as well. There's already, you know, whether it's RHA or other partners, Mobile Care Chicago, there's so much great work, evidence-based work happening in the community. How do we coordinate those efforts so that we can leverage, because we're all working with less, but expected to do more? How can we kind of leverage everyone's expertise and resources so that we can collectively move the needle? So I think, you know, the project that Erica mentioned, where it was multiple institutions working together to address, you know, their area of expertise and looking to serve a greater population with a variety of different interventions. That's really what we need more of, that resources to support that added coordination and collaboration, but more coordination across institutions and public health system, you know, whether it's community level, schools, connection to community and CHWs. So I think any way that we can make those connections across the different public health system is really going to help move the needle as well.
Great, thank you, Amy. Erica, do you want to share your thoughts on how do we change the story in the next 5 years?
I think that we have to do everything Amy said and deal with those social determinants of health. I want to say we did a study a couple years ago looking at air pollution we were looking at asthma relative to people's proximity towards CTA garages and turnarounds and where those families lived relative to the higher volume routes where you get more pollution. And we found a relationship, and those people that lived in the smaller radius near those busier routes and lived near the garages or the maintenance garages had higher rates of asthma, except when you controlled for social vulnerability index that Amy talked about. So in Chicago, on the north side, North Halsted has a very big bus route, and it has a much higher, they do much better on social vulnerability index. So this is why I struggle with this so much, is because yes, the housing and the transportation, it's all so important. But at the same time, we have to deal with the people that are experiencing the conditions now. The other thing I would say is support RHA's efforts and Little Village environmental justice organizations' effort to get these friggin' diesel engines out of our communities.
Great, thank you, Erica. Nancy, I want to give you a chance to answer the same question. How do we change the story for the next 5 years?
I'm gonna answer as Nancy and not Nancy at IDPH because I didn't get to talk with Nikki before. You know, I don't want to say anything out, but from my perspective, from an EPI perspective, I think probably one thing that we could do better is by supporting our partners by doing kind of smaller area analyses, because right now we really kind of focus on looking at counties. And I think within counties, there's so many little nuances in there that we're probably missing some pockets of Illinois that really need support. I think we have to continue doing the policy work that we've been focused on because we are a state agency, and it is hard to kind of go in there and target. And so it's like being able to provide the data that our partners need, but then also focusing statewide. And I feel like it's interesting. I also support the injury program at IDPH, and they're really focused on social determinants of health and risk and protective factors that are seated very low. You're not even talking about health conditions, right? You're talking about social determinants of health and all those factors. And I feel like some of the asthma work might need to step back and focus on those. And not that we're not, because we are focusing on projects like one of Dr. Vollerman's projects where they're setting up the provider network, the ECHO network, right, to like kind of push policies and kind of hope to elevate some of the guidelines-based medical management stuff, making sure people get those things. But I think when you're talking about moving the needle, we have to go like really micro. And at the state, we're kind of macro. So, yeah.
Awesome. Thank you very much to all of you for your participation as speakers. And thank you to everyone who joined us today. I hope you learned something new as it relates to asthma data, asthma care, and where we can all work together to go from here. If you have any questions or any feedback for us, don't hesitate to add it in the chat. And I know that there is a ending slide. So reach out to Asher with any questions or feedback, and please fill out the brief evaluation form, as it does provide insights about and feedback to the event today, but it also helps shape where we as an organization go in the future. And then, as Matt mentioned at the beginning, visit our website, and if you're looking to get involved, there's many opportunities to volunteer on our committees or on the board, and definitely reach out to Asher for insights on that. So thank you very much, everyone, and have a wonderful rest of your day.